Hi, everybody. It's really my honor to talk about biomedical HIV prevention for women. We had the pleasure of listening um, to Mia Biondi and Molly Bannerman uh, a month or two ago, who spoke about their HIV prevention work for women and the research they've done and the programming they're aiming to do. And this talk today is going to talk more about the actual medications we use to prevent HIV amongst women. When I talk about women, I'm talking about cis and trans women and gender diverse people. I acknowledge the land and waters where I live and work as the traditional territories of the Anishinaabe, Wendat, and Haudenosaunee, and these lands are covered by Treaty 13 with Mississaugas of the Credit First Nation. These are the objectives of my talk today. Um, First of all, I'll briefly review the epidemiology of HIV among women in Canada and how it's actually quite alarming. I'll then review the new 2025 Canadian HIV pre-exposure prophylaxis, known as PrEP, and post-exposure prophylaxis guidelines, and consider them in the context of women. So this talk is quite timely since the guidelines just came out December 1st, 2025. Then I'm going to summarize the evidence for PrEP for women, really mostly by discussing the clinical trial data of the drug specific for women, and then briefly address pregnancy issues like contraception, pregnancy, and breast or chest feeding in the context of HIV PrEP. So let's get started looking at the epidemiology of HIV uh, among women in Canada. You may have seen that the 2024 HIV epidemiology data was released as a surveillance report on December 1st, 2025. So for those of you who don't know, December 1st is World AIDS Day, where we honor those that we've lost from HIV and we recommit ourselves to the fight uh, for HIV. And so on December 1st, every year in Canada, the incident rates, the new case rate from the prior year is released. So December 1st, 2025, the incident rates and the new case rates would have been released up to December 31st, 2024. So for the year 2024, there were 1,826 new cases diagnosed of HIV, but that does not include Quebec. Quebec did not submit their data, which is interesting. And so you can see the incident rates across the country. And then what I went and did was I went and I looked back at what the incident rates and the new case rates were in the different provinces. The last year it was reported in the surveillance report, detailed surveillance report from released in 2024. And I would predict Quebec would have about 450 new cases. So we're still looking at a total new diagnosis rate in Canada over 2,000. So about 2,275 new cases of HIV in Canada still per year. And you can see if you look at the incident rates, some areas like BC have been able to reduce their rate quite a bit to 3 new cases or diagnoses per 100,000 population. Atlantic Canada, 1.7 new cases per 100,000 population. That's how we summarize new case rates or incident rates. But if you can see the middle of the country, Saskatchewan has an incident rate of 18.6, and Manitoba 19.5 per 100,000, which is quite alarming. This is the breakdown by sex. New cases of HIV in Canada are not reported by gender. They're reported by sex. So female versus male. And so you can see there by of the 1,826 new diagnoses in in 2024, 659 were in women, and that means 36% of the cases in 2024 were amongst women. And I could show you a diagram how that's increasing. That's been increasing over the last 10 years, with even just 5 years ago, that proportion was 25%. And that can also be seen by the increasing incident rate per 100,000. So in 2024, for women, there's an incident rate of 4.1 per 100,000. And you can see that that's been increasing almost every year over the last 10 years. And from 2022 at 3.0, 2023 at 3.9, and now 2024, 4.1 per 100,000. So new case rates and proportion of new cases amongst women is increasing in Canada. I think this is a serious women's health issue. And in those prairie provinces that I was talking about, the proportion of the new cases that are women are half. So are 50% or even higher, 55%. And this is known as the feminization of HIV. This is the distribution of the exposure categories. So amongst males, oh, I missed you can see at the bottom, which is the tells you what the different categories are. And so what to really hone in on is amongst women, 47.3% of the transmissions are happening from heterosexual contact, and 37.2% from injection drug use, and 15.4% from women other or we don't know. So that heterosexual contact is a very important and key mode of transmission and acquisition amongst women and gender diverse people that we really need to look at, including injection drug use. Something we don't talk about a lot also regarding HIV prevention is that individuals who are able to get pregnant and who acquire HIV have the risk of transmitting to their infant. And we have about 250 infants born to people living with HIV in Canada every year. We do a very good job working with these people and they take combination antiretroviral therapy during the pregnancy. However, in more recent years, we have had increasing rates of perinatal transmission in Canada. So in 2024, there was one infant born with HIV. And then the year before that, or a couple of years before that, there was 3. So this is a phenomenon that's increasing in Canada, which is another important reason to think about HIV prevention amongst women and people who could get pregnant. Okay, now I'm going to go over the 2025 Canadian HIV pre-exposure prophylaxis, PrEP guidelines. They're also on post-exposure prophylaxis, but I'm not going to expand as much on PEP. PEP is when you take the medication after the exposure. HIV pre-exposure prophylaxis is when you take medication before exposure of HIV to prevent HIV. Both are for prevention. So here they are. Here are the authors. They did a great job. Um, you can see that the first recommendation is on counseling, that all sexually active adolescents and adults and those who inject drugs should be counseled regarding PrEP and PEP as part of a comprehensive approach to preventing HIV and other sexually transmitted and blood-borne infections. They should be made aware of the excellent safety and efficacy profile of PrEP and PEP and how they can be accessed. And this information should be framed in a positive light to counteract the stigma and apprehension that sometimes surrounds PrEP and PEP. And this is written as a good practice statement. The guidelines also comment that PrEP shouldn't be denied from anybody who wants it. This is the next section in the guidelines on PrEP. And you can see here, I'm going to go through this in a little bit more detail when I go over the evidence for PrEP amongst women. But in terms of the indication, who should be prescribed PrEP, the guidelines say that it's appropriate to prescribe PrEP to adults and adolescents who request it. Clinicians are encouraged to assess HIV risk, and there's HIV risk assessment tools that can be used, and that should be done during routine health visits to identify who's at increased risk and could benefit from PrEP. And that's particularly amongst those who don't request it themselves and people who are at higher risk of HIV acquisition, it should be recommended to them. And I think that's actually probably something that's not happening for women. For people suitable for PrEP for the prevention of sexually acquired HIV, whose sex is assigned at birth and gender identity, or that of their partners are not specifically named in the recommendation below, clinicians should follow recommendations that align with the person's anatomy and sexual partners. I think we asked for that statement to be put in, so I'm really happy to see it. So the regimens that can be used are for all HIV negative individuals. The most common regimen used, and the first one that was studied, and the first one approved by Health Canada, was taking 1 pill a day. So it's a daily oral pill of tenofovir disoproxil fumarate, TDF, with FTC, as a combination pill known as Truvada. And that's highly recommended and recommended for all groups. There's another way that Truvada can be taken, which is on demand. So it can be taken on demand 2 to 24 hours before sex, 2 tablets of Truvada, then 1 pill every day that you're having sex, and then 1 pill a day for 2 days after your last sex act. So if it's one event of sex, you take 2 pills. Let's say you're having sex on Friday night, you take 2 pills on Friday during the day, and then 1 pill on Saturday, 1 pill on Sunday. The caveat with that is that the guidelines do not recommend on-demand PrEP for women. because there aren't the studies for it. It was only studied in gay and bisexual men who have sex with men and trans women who have sex with men, but there weren't enough trans women in the studies. So that is an area that needs more work. And some other guidelines do have on-demand regimens that they recommend for women. There's also another regimen available for a daily oral regimen that's available for PrEP that includes tenofovir alafenamide, which is a different formulation of TDF, which potentially has less of an effect on the kidneys and bones, also combined with FTC, and that's known as Descovy, and that can be taken every day for PrEP, and it prevents HIV to an equivalent rate as Truvada. The caveat there, again, is the original study, known as the Discover study, was not conducted in women. And so actually in Canada, Descovy is only labeled for men. I'm going to show you the result of a study that did look at Descovy in women. And so there's applications to change the labeling to use Descovy in women, but that hasn't happened in Canada yet. The latest regimen that has been approved to be used for PrEP is an injectable PrEP known as Cabotegravir. It's a 3 milliliter syringe that can be given with an oral lead-in. You can take a pill for 1 month and then get a first injection. Then you get a second injection 1 month later, and then every 2 months. And I'm going to show you the studies of that. But there are some caveats about the use of that drug for prevention, and that one is available in Canada with very good studies in women. And you can see there that there's a bit more details about what can be used for cisgender men. They've included on-demand PrEP for biologic reasons. They've included TDF-TAF, but you can see there for HIV-negative cisgender women, on-demand PrEP is recommended against, and TAF, FTC, Descovy may be considered for the reasons I told you. And then there's even more caveats related to people who are at risk who use injection drugs. Similar to women, as you can see, which is interesting. But one of the things I always say when I talk about HIV PrEP for these different groups is that people who use drugs and could acquire HIV from injecting drugs or using drugs also very often have sex. So they actually are at risk of acquiring HIV, not just from the use of injection drugs, but also from sex. So that actually they fall into the other categories of and which drugs are applicable to them. This is a nicer sort of table that summarizes what I just went over, which may be a better way to present it. So basically, oral Truvada is the first and most widely available and can be recommended for all groups. The on-demand PrEP is mainly recommended for men who have sex with men, may be considered for cisgendered men who are heterosexual, but is recommended against for cisgender women and people who inject drugs. Daily Descovy may be considered for everybody. And the injectable CAB, you can see there, is recommended for men who have sex with men and cisgendered women. Um, I'm not going to go through this in detail. It's in the guidelines, but they really go through very well. This is um, the details of how to do the counseling in terms of sexual risk taking, what to do at baseline and follow-up in terms of HIV testing, managing a suspected HIV seroconversion case, um, some monitoring of organs that could be affected, um, managing of other sexually transmitted infections, frequency of follow-up, which is typically every 3 months. And they do say that in terms of, you can see there in the second column, for reproductive health considerations, routine testing for pregnancy is warranted if applicable. And then some more counseling and some more counseling specific in different populations. This is the laboratory evaluations that are recommended at baseline and in follow-up. And then the other point I'm going to go over that the 2025 guidelines do go over and is really nicely summarized by this um, knowledge translation tool that Y made, the Women HIV and AIDS Initiative. And you can order it or download it if you go to the Y website. But they summarize, and the Canadian guidelines support this, that there's really a choice of biomedical prevention. Somebody can choose HIV pre-exposure prophylaxis with that menu of different drugs I went over. They can choose PEP. PEP is when you take 3 HIV medications at once, usually in a single tablet regimen, or in 2 different drugs, like with Truvada and dolutegravir or Biktarvy, but it has to be started within 72 hours of the sexual exposure, and it's taken for 28 days. That's what PEP is. And they also talk about another way to use PEP, which is PEP in pocket, which our very own Dr. Isaac Bogosh and Carla have done a lot of research on, about maybe someone who isn't at great risk all the time, but they have a PEP prescription. And if an event happens, they can fill that prescription and take PEP. And so that's known as PIP. And the guidelines and this document really summarize that an individual interested in biomedical HIV prevention has a choice to which one they want to use. I have a bias for PrEP, and I'm going to show you, and that really comes from the rigorous and substantive clinical trials that have been done using HIV PrEP. And so I'm going to go through those with you now. So actually, when the initial studies were done using Truvada for daily PrEP for women to prevent HIV, the first couple of trials actually showed that it didn't work, which is amazing and so interesting. And a lot of times when these um, uh, types of medications are used with women at the beginning, women don't trust them, and they often don't take the pills and medications. So when you're doing clinical trials with women, you really have to assess adherence. And but then after that, more and more studies came out with women and using Truvada for PrEP. And many of the studies incorporated peer support. They incorporated um, aspects where women were supported in the clinics, had an area where they could meet, where they could use internet and so forth. And those were the activities and aspects that really supported women using Truvada for PrEP. And so this is a summary of 11 demonstration projects um, in various countries across the world, mainly African countries and in India, and where over 6,000 women um, were enrolled that used Truvada for PrEP. And I just want to show you that at 10 years ago, when the initial studies came out saying, oh, Truvada doesn't necessarily work for PrEP for women, more and more studies came out, clinical trials, and finally, this summary of these demonstration projects, you can see that that the HIV incidence for women, which I think, do I have it on the slide here? Was thought to have been, it was supposed to have been around 3 per 100 person years, was down to 0.72 per 100 person years. And so that PrEP and Truvada for PrEP for women works. And then in this analysis, they also did a sub-analysis looking at adherence. And adherence is uh, particularly important for women for PrEP because there's potential different levels of concentrations of the medications that end up in the vaginal mucosa. However, you can see for of the women who consistently took Truvada every day, there was 0 cases of HIV. And then even if you take, we try not to tell people this too much, but you can actually miss a pill a week or 2 or 3 pills a week, and Truvada every day still works. And so you can see there only 1 case out of 658. And then it even works if you take it a few times. We try not to promote that, but definitely taking it 6 to 7 times a week daily, Truvada works for PrEP for women. Okay, so then the probably the biggest breakthroughs for PrEP for women are injectable PrEP, and just wait till you see these data. So Cabotegravir, long-acting, is an injectable antiretroviral. And so this is a randomized control trial among cisgender women. The trial is called HPTN 084 and is conducted in 7 African countries. And if you can imagine, 3,224 women between the ages of 18 and 45 were enrolled. And they were randomized to receive Cabotegravir with an oral lead-in or Truvada. It's double-blinded, so they receive both actually. And then they're randomized to receive the injectable PrEP or Truvada. And because it's blinded and randomized, they actually receive both and they don't know which one they're on. And so the group that got Truvada even gets a placebo injection. That's how these studies are designed. And they're followed forward in time with a 1-year unblinding, and then an open label extension after that. There's a similar design amongst men who have sex with men and trans women who have sex with men, and it's called P083, and I'm not going to go over that because of time. But look at these results. This is at the end of the 1 year mark. So the primary endpoint that led to labeling, that there were only 3 infections in the group that received the injectable, Cabotegravir for PrEP, and 36 infections in the Truvada arm. That is a 90% reduction of HIV acquisition amongst women for the injectable PrEP versus the oral PrEP. Something that is a concern with the injectable PrEP is that in the study with cis men and trans women, there were actually 6 infections that happened with on-time Cabotegravir injections. And we don't know necessarily why, but that is a concern. You can see that the 3 infections that happened in the women in the blinded phase happened. One was there was no recent cab exposure, and then in the bottom, in 2 of the cases, and in the one, the Cabotegravir was delayed. So in women, infections happen when the Cabotegravir is delayed, and then there was 1 infection in the baseline that we didn't count. However, what's different in women compared to cis men is that women had 0 infections if they had on-time Cabotegravir infections. And it's believed that the Cabotegravir depot that gets injected does better in women, that it's released better, and that the responses are better in women. This is another study. This is one that I love. It was done in Kenya and Uganda, and it's called the SEARCH study. And what they were offered, they were randomized. So 984 individuals, 73% of them were women, were randomized to receive a dynamic choice of HIV prevention options. So they could choose oral PrEP Truvada, they could choose injectable Cabotegravir, they could go back and forth, or they were randomized to the standard of care. And the primary outcome was looking at the percentage of time that they received PrEP coverage, and it was 70% in the dynamic choice HIV prevention arm and 13%. 13% in the standard of care. It's so low. But not just that. There were 0 infections in the women who received the dynamic choice experiment, and there were 5 infections of HIV in the standard of care, and also 1 infant was born to a participant in the standard of care with HIV. So I say this repeatedly, women like choice. And so I really like this study showing how offering choice is important for women. And you can see the breakdown of who chose what on the left. And then this is a study showing the different satisfaction with the use of the different regimens. And with long-acting CAB, just that that many of the participants were satisfied receiving long-acting Cabotegravir injections. This is another incredible study about long-acting injectable PrEP for women, uh, conducted by Gilead. This drug is not available yet in Canada. It's not licensed in Canada yet. It's been submitted to Health Canada, but it is approved in uh, the it is approved in the US for prevention. So it is given as um, a 3 milliliter injection, like two 1.5 milliliters subcutaneously in the abdomen. I've given it for HIV treatment, but not for prevention yet. So, and it's called lenacapavir. And what's really nice about what this company did is they saw the gap of HIV prevention studies in women. And so the first study they did was called Purpose One, was in and with cisgender women age 16 to 25 in South Africa and Uganda. You can see there they enrolled 5,368 cisgendered women, and they were randomized to what we say 2-1. So you have to get a loading dose of the lenacapavir with like pills on day 1 and day 2, and then you get the injection on day 2, and then you get these injections every 6 months. So that's pretty incredible. And then the comparator groups, this is the study where they studied TAF FTC. So Descovy was given amongst 2,136 women. And then the comparator group, 1,068 women were given Truvada. And they were followed forward in time, and HIV incidence was the primary outcome versus the background HIV rate. And I believe there wasn't an end date. It was based on HIV incidence of when the analysis was stopped. These results were presented at AIDS 2024 in Munich and was just breakthrough because the background rate, like I told you in that in the those 11 demonstration projects are around 2.41 or 3 per 100. And in the group that got injectable len for women, there were 0 infections. Isn't that incredible? And then 39 infections in the Descovy arm, but remember they had double the number of cases compared to the Truvada arm, where there were 16 infections. Now, I've showed you now these demonstration projects, clinical trials showing how amazing PrEP is for women. However, in Canada, PrEP is not being used in the prairies where majority of women are acquiring HIV, and also not being used in other provinces amongst women. This is overall something that we call this is the PrEP prevalence rate. We can calculate something called the PrEP to need ratio, where we take the proportion of people on PrEP and divide it by the number of HIV cases. And it's almost 0 for women across Canada. So if we have these amazing clinical trials and results of efficacy of HIV PrEP medications for women, why aren't they getting accessed in Canada for women? Also, women are less likely to be tested for HIV. Women are less likely to be offered PrEP at the time of an STI diagnosis. And that STI diagnosis can be in a STI clinic, in a women's health clinic, in the emergency department, and PrEP is not offered. Why? And what are we going to do about it? what are we going to do about it is not it's not the topic of my talk today. I'm running out of time, so I am going to just show a couple of slides. Or maybe I'll just show this slide and then open it up for questions. Um, because really, in summary, and the 2025 um, Canadian PrEP guidelines really summarizes it well. As a recommendation that people who are pregnant or breast or chest feeding, they can use standard um, TDF, FTC-based PrEP can be offered, Truvada, lots of studies with Truvada and pregnancy, and it's fine. And then the use of TAF or CAB long-acting for PrEP uh, for in pregnancy, counseling should occur with shared care decision making. However, the DHHS comments and the CDC comments that CAB for PrEP may be initiated or continued in people who become pregnant while receiving injections when anticipated benefit outweighs the risk. And I am going to these are just the slides showing the safety of cabotegravir in pregnancy and breastfeeding, as well as with contraception. So just in summary, in conclusion, the incidence of HIV is increasing amongst women in Canada. There actually really isn't very good epidemiologic data of HIV among trans and gender diverse people, something that we need to work on. I presented the new 2025 Canadian HIV PrEP and PEP guidelines, which I think are really well written. I've summarized the evidence uh, for biomedical and really PrEP using medications for women. There's lots of options with amazing injectable PrEP results, and that contraception in pregnancy is fine in the context of HIV and PrEP. And I'll end there. And Amy's going to put in the evaluation in the chat. Feel free to reach out to me anytime.